tandem to each other. So everything has a ratio. We never measure your estrogen alone and say that your estrogen is high or low. We always measure your estrogen in relationship, say, for example, to progesterone. We measure your testosterone in relationship to your progesterone. And we measure your testosterone in relationship to your DHEA. Everything works in a ratio form. That will make you the way you are. So your character is governed by each ratio. The last line saying multi-hormones needed for a balanced, healthy living. So remember, by the time you are ready to reproduce, you only have a few hundred eggs left. Next. Next, please. So what kind of patients will come to me and say that I have a female hormone issue? The most common will be this thing called the estrogen dominant, otherwise also known as luteal insufficient. What happens to this kind of people is they come in saying that I was told my hormones are out of whack. I was told my hormones are imbalanced. Can you please help me? So what do they come in complaining about? Next slide, please. No, the one above. Keep going. Up, up, up. I think you missed a few slides. Keep going back up. Some more. Up. Up, up. Keep going. Some more. Wow. Keep going. Okay. Stop. Okay. So a typical profile of a lady that comes in and tell me that she thinks she has hormonal imbalance will be somebody from the age of about 35 to about 45. And these people tend to be what we call a gynoid shape, or as the Asians would say, somebody who is quite fertile looking. So somebody who's a bit more round. And next slide. When they come in, they tend to look a little bit like this, a bit on the rounder side. The breast is a little bit large. The hips are a little bit large. Next slide. Okay, I want a slide after this first, if you don't mind. So they come in and they tell you, doctor, the week before my menstruation, I get mood swing. My husband leaves me. My children run away from me. I'm one of those that, have a pre-period and post-period clothes. The week before my menstruation, I need to have one size of dresses. After my menstruation, I can go back to my normal size of dresses because I retain so much water. And I'm one of those that have sugar cravings. The week before the menses, I'm raiding the fridge for chocolates. My breast becomes very tender. I lose my hair. I can't sleep. Or even if I can sleep, I wake up in the middle of the night. And 1 minute I'm crying. Next minute I'm irritable. I'm shouting at my children for no apparent reason. And I get cyclical acne. So people say, oh my goodness, it's like I've got second childhood. I never had acne when I was growing up. Now I've got acne. And it comes and it tends to be around the chin area, here and here. They don't get acne above here. It tends to be the bottom half of your face. They may lose their hair. They become very fatigued. And whenever they do their health screen, they say that, doctor, I am always told that I have fibroids, or in Indonesia, it's called myom, or kista, which is ovarian cysts. And they always get breast nodules. Some people will actually present with a history of PCOS, polycystic ovarian disease. Can you go back to the slide before? So, no, this one, yes. So they come with multiple issues, and it is quite obvious that everyone says that, your hormones are out of whack. And I'll explain to you why that is the case. If you look at this graph, you look at the graph, it says estrogen. Then below that graph, it says progesterone. You notice there is a huge dip in the progesterone from the age of 35 to about 50. There is a 70% drop in progesterone in that over 10, 15 years. Whereas comparing to estrogen, yes, we know that after the age of 40, our estrogen starts to fall, but it falls at a much gentler slope comparing to the progesterone. So because of that, the estrogen to progesterone ratio gets higher and higher and higher every year. And that's why we call it the estrogen dominant syndrome or luteal insufficiency. And it is this ratio that is giving you the symptoms, because estrogen, no doubt, is excellent for multitasking, for brain, for remembering, for memories, for a lot of things that make us the woman the way we are. Without the control of progesterone, it makes us very womanly. That means emotional, clingy, crying, irritable, short temper, and it makes us crave for sugar, water retention. And of course, as you know, estrogen exposure to your womb and to the breast is not the greatest. So we always need progesterone to counterbalance the excessive bad side effects, symptoms of estrogen. Now, progesterone helps you with the sleep. Progesterone keeps you cool, calm, collected. I call it my meditating hormone. That's what progesterone does for me. Yeah. Okay, next slide. 2 slides after, please. So what caused this kind of imbalance? The first one is a natural cause, which is the slide I show you. But more and more people, it's because it's the lifestyle we are all living. Xenoestrogen, phytoestrogen, what does all that mean? Phytoestrogen will be things like soy. You know, everyone thinks soy is very good. Everyone should take soy because soy makes Asian women look very beautiful. All the Caucasians are all eating soy. You have to remember the reason why we eat certain staple is based on our DNA. Caucasians and soy are not good friends. Caucasian and soy will increase the risk for thyroid dysfunction, whereas it doesn't increase the risk for thyroid dysfunction in Asian. And I think a lot of it is a DNA predisposition. So phytoestrogen will be things like soy, and that's why generally Indonesian ladies have got beautiful skin and they tend to menopause a bit later because they take a lot of soy in their diet. Tempeh, you all eat tempeh every day. And if you look at all the ibu, they have beautiful skin. So that is one of the reasons. But if they don't have enough progesterone, then they are a little bit of a nightmare, just especially before the menstruation. You know, they start yelling at people, they start scolding people, they start to have mood swing, and they start to crave for a lot of sugar and put on weight. Now, what is xenoestrogen? Xenoestrogen, unfortunately, is now one of the most common chemical that is ingested by the world. Plastics, cling film, microwave, paper cups, plastic plates. And if you go to your hawker center, you buy your noodles, it's all bagged in little plastic bags. Now, all of these contain xenoestrogen. That means they are what we call fake estrogen-like molecule. And the more you consume, the more it will hide in your adipose tissue. And adipose tissue, fat cell is what I call a toxic vat. Fat cell love to absorb xenoestrogen, love to absorb phytoestrogen, love to absorb any kind of an oily molecule. And then it will actually propagate and make you fatter. And when you have more fat, you absorb more of this xenoestrogen. And the more xenoestrogen you absorb, the fatter you become. So it becomes a vicious cycle that is no ending, and you will definitely grow sideways. So xenoestrogen comes from plastic bags, the plastic container that you get from the hawker center, microwave, and a lot of the paper wrappings, plastic wrappings that you get. So if you really want to avoid xenoestrogen, don't use microwave, don't use plastic, anything plastic, and you eat off what we call glass plates. Glass plates has 0 xenoestrogen. Okay, next page, please. So in order to establish that we actually have that problem, you need to take a proper history, like the first page that I showed you. You ask them what they're complaining of and when is the worst time for them in this monthly cycle. And you can confirm it with diagnosis, either a blood test or saliva test, depending on where you stay, which country you come from. I like to do blood of late. I've stopped doing saliva because I find it a little bit too oversensitive. But if you want to check the ratio of the different estrogen, you need to do it in saliva form. And what can you do once you find out that they are out of whack and the ratio is wrong? I like to use this thing called the bioidentical hormones. I like to use plant-based, bioidentical, progesterone, transdermal application. What does that mean? It means that the progesterone comes from plant, it's been synthetically spun down, and the molecule of the progesterone that you take or apply is identical to what your ovary produces. That's why it's called bioidentical hormone. And I like to use transdermal. That means application, you apply. Now, why is application better than taking? Because everyone's amount, you and your twin sister may have identical amount of hormones, but both of you will require different amount of progesterone and ratio to feel good. No one is exactly the same. So if you use transdermal application of cream, I can break up the cream into 0.1, 0.2, 0.3, 0.4. Well, if it's what's the word? A tablet, I can break the tablet into 8 pieces. Yeah. Some people say wild yam. You have to eat a lot of yam. You'll be 100 kilos before you get enough progesterone. And the top that says progestin or the synthetic pill, I do not use. Progestin is not progesterone. Progestin is only 70% identical to a progesterone molecule. So why would you use something that is only 70%? Let me put it in perspective. Estradiol, which is your estrogen, and testosterone is 98% identical. So if you need estrogen, would I give you testosterone? No, I won't. But it's only 2% different. So why would I use progestin, which is 30% different from our progesterone? So I always and only use bioidentical hormones. Next page, please. And the question that should be on everyone's mind is, okay, so I'm going to take progesterone, I'm going to apply progesterone. How long do I need it for? Well, it depends on the cost, right? If it's a pure, simple estrogen dominant thing, then you know that as the years go by, the estrogen will start to fall and the ratio does correct itself. So most of the time it's between 18 months and 2 years. Menopausal women, we use it for different reasons, not for your PMS reason. We use it for sleep. We use it for irritability. So we may use even up to 5 years. Okay. Next slide, please. So that's all done with hormonal imbalance. I think I will only take question when I finish everything. Next, menopause. Everyone is dreading menopause. Okay. Next slide. Next slide, yeah. So this is a very fancy way of defining menopause by WHO. Is permanent cessation of menstrual period. That means no menstruation, whether it occurs naturally or induced by surgery, chemotherapy, or radiation. Yeah, this is in accordance to the National Institute of Health in 2005. That means 1 whole year of no menstruation. So 1 calendar year, 12 months. Okay, next. Yeah, 12 consecutive months without menstrual period. Next slide, please. So who come and say that they have menopause and not hormonal imbalance? The symptoms are a bit different. Obviously, the most common symptom will be hot flush. And people say that, you know, it's like someone putting a fire or radiator next to you without telling you. All of a sudden, you start to sweat, and you tend to sweat around the neck, You tend to sweat where all the flexion is, you know, the wrist area, the elbow, the armpit, and of course, where your panty line is. Insomnia, cannot sleep. Either cannot sleep, that means you have problems going into sleep, or I sleep at 12 midnight, I wake up at 3:30 in the morning and I'm staring at the ceiling. I cannot go back to sleep. On the dot every night, 3:30, I'll wake up. So you either can't go into sleeping mode, or you can sleep, but you wake up in the middle of the night. Weight gain. I can tell you this weight gain thing, nobody can run from weight gain. Nobody. And that includes Jennifer Lopez, Angelina Jolie. Nobody can run from this. It's because of our DNA defense. See, when we go into menopause, our ovaries stop producing estrogen. Now, estrogen is our longevity hormone. It keeps us alive. It allows us to multitask, memory, against Alzheimer's, heart disease for a long, long, long time. It promotes longevity in us. Your DNA says the minute your ovary goes into retirement home, it must find another source of organ to continue to produce a little bit of estrogen the rest of our life. Where are we going to find that source? Fat cell. It comes from our fat, yeah? So estrogen is produced in adipose tissue. So whether you like it or not, the best area to produce estrogen is the hip area because it has the most adipose tissue. So if you are very worried, you have got to make sure that you exercise and you maintain the weight. Your weight, whether you like it or not, will go up about 10%. It will go up 10%. So if you're 50 kilos, it will mostly end up being about 55 kilos post-menopause. That is if you're lucky. A lot of people who don't realize that that is happening, they'll end up 10, 15, 20 kilos. So if you know menopause is coming, you are careful with your diet, you are very good with your exercising, and you do all you can to maintain a simple weight, your weight will most really only go up by 1 dress size. This, I'm talking to all women, and that includes myself. I am 55 years old. I put on about 8 to 10% of my weight post-menopause. Can't run. The next thing is, of course, people say your skin is very papery, very thin skin, very dry skin, dryness of the vagina, and low sex drive. Hair loss. Your hair become very thin, become very sparse. And when your estrogen is low, you have low, flat mood, which is depression, or the blues, as I call it. Sometimes you have emotional, you become a little bit emotional because the estrogen is trying to peak and then it drops, it peaks and it drops. Whenever it does that, it makes you have what we call mood swing, irritability, memory loss, and unable to multitask. I like this multitasking thing. You know, when we are in our mid-30s, we can pick up the children from school. On the way home, we go to the dry cleaners, then we go and buy bread, right? You give that task to your husband, either the bread get left behind or the child get left behind, or your dry cleaners have gone and disappeared. You see, it's because of the estrogen, it allows us to multitask. And that's why women, we can go to work. We come home, we are the CFO and the CEO of our own household. We are the CEO and CFO of our workplace. A man, they may be mathematically much better, map reading much better, but they cannot multitask. They have got other users, but they cannot multitask. We have got other users. And that is why when you know, the hormones of a male and woman, it's very interesting to look. I always like to tell this story where if you're both 35 years old, a man and a woman, a man is full of estrogen, right? Testosterone, and the woman is full of estrogen. And if you look at them, they're very lovey-dovey, and the woman is clingy. And every month, the week before the menses, the husband always say late, he doesn't want to come home because she's crying and yelling at him. And what happens is you notice when they walk in the supermarket or they walk in the in the shopping mall, the man is walking half a pace ahead of the woman. She's following slightly behind. And then usually when she's clinging to him, he wants to go out with his guy boys. He wants to play football. He wants to go and do stuff with all the boys. He doesn't want to stay at home. Then you fast forward 20 years down the line, a man and a woman, both 55 years old. And you watch them this time around. You notice the woman is now one step ahead of the man. The man is always following the woman from behind if they're both 55. It's very interesting to look. This is because there is no more estrogen in a woman. The estrogen in a man now has risen because his testosterone has fallen. A 55-year-old man has more estrogen than a 55-year-old woman. And so there is a reversal of role and behavior. So it is quite funny to watch. It's very, very interesting. Okay, next slide, please. So these are the things that the estrogen is supposed to do. So it picks up our breast, right? So when we have no more estrogen, the breast go down south, everything goes down south. Our body hair, pubic hairs become sparse, and our bone mass starts to fall. We become osteoporotic, but more importantly is the cardiovascular risk. And that's why we do not like you to menopause early. We are very worried about your sakit jantung, yeah? Because pre-menopause, you almost unheard of a woman suffering heart attack. But the minute you become menopause, your heart risk equates a man. So that is very important. You should not menopause before your time. Next slide, please. So what causes menopause? Natural aging process? Yes. Premature. And we are seeing more and more premature. It's called premature ovarian failure. That means your ovaries actually retire before its time. What is the expected age of menopause? 25, 30 years ago, the minute people say, I come 48 years old, oh, I'm so happy I'm menopause. I don't have to buy any more tampons. I save money. Honestly, that is all you save. Everything else go down south. Today, because of our lifespan being 88 and a half, I don't like to see a woman menopause before 53, 54, and even 55 years old, because it protects us against Alzheimer's, heart disease. So why are we seeing more and more young ladies prematurely menopausing? Stress. People don't realize how important stress. I do not know who is giving the talk on adrenal fatigue and stress and cortisol. It's a very, very interesting correlationship of the adrenal and how it impacts the rest of our hormonal organs. So we're seeing more and more people menopausing earlier, and we're seeing more and more infertility. Surgical means you had an operation due to cancer or for whatever reason, and they removed the ovary. So that's called surgical menopause. Next slide, please. So what do? Well, we can do nothing, which is what most people do. You can have lifestyle change. You change your diet, improve a more natural estrogenic diet in your daily foods. Phytoestrogen like herbs, soy, minerals. You can do zinc and selenium that improves your ovarian function. Herbs, what can we do? Chase tree berry, black cohosh. Speak to your doctors. They should be able to, every integrated practitioner should be able to tell you what herbs to take. Soy, Indonesian, continue on a tempeh. And 25, 30 years ago, they used to give this thing called HRT. HRT is hormonal replacement therapy. Actually, we don't like to use the word hormonal replacement therapy. I like to use the word bioidentical supplementing therapy, because you're not replacing, you're supplementing. And so the non-identical one, the ones that our mothers used to take, all came from horse, equine source. You know, they get a pregnant horse, then they make the horse pass urine, and they filter the urine, they dry it, they put it in a little capsule, and they give it to you. You are not horses. Why take horse hormones? So I only use identical hormones. Then there's this thing called monotherapy versus multitherapy. Remember, the ovaries produce 6 things, right? 6 hormones: estrogen 1, 2, 3, DHEA, testosterone, progesterone. Why would you only give estrogen alone, estradiol? It doesn't make sense. Okay, next slide. So it's a bit, I apologize for this slide, it's a little bit blurred. So if you look at the tofu, the soy, the foods that you take, that is what we call phytoestrogen. Then if you look at the HRT that comes in the capsules or tablet, then you look at the bottom two. One looks like like a little kueh boxes. Those are Troche. Those are little gum paste that you put it. They contain hormone, and you put it inside your mouth, under the tongue, or next to your cheek, and you rub it in. It will enter your blood system. I like to use the bottom corner that says the cream, because the cream, you can change the amount that you use based on your needs. If you are a global CEO and CFO, you may need a little bit more of everything. If you are just a lady of leisure, you may not need so much. Okay, next slide. Yeah, so this is exactly what I'm saying. So if you go on oral supplementation, phytoestrogen like your tempeh, minerals and herbs we spoke about, there is still the option of the old-fashioned horse urine HRT. Cancer risk is higher than bioidentical HRT. Now, it doesn't mean that the bioidentical natural hormone has no cancer risk. It's just that it's much lower. So your doctors should always do a breast baseline mammogram with breast ultrasound and ultrasound of your womb before starting you on any kind of hormones, any kind of gonadal hormones. Yeah, you must always get a baseline. So I like to use the word transdermal, Troche. Some people like to use that. Injectables are more for, I would say, male hormones. And implants I don't like, because you put it in and it's supposed to stay for 4 months. Well, anyway, it's non-identical, and it contains things like progestin, and it contains things like estrogen, which I don't like, which is higher cancer causing. And once you put it in, if you don't like it, you got to cut it open and take it out. So not ideal. The cream, you apply every day. You don't like it, you stop. Within 24 hours, it has left your body. Next slide, please. So why do we treat? We treat because we want to alleviate the symptoms: hot flush, dryness of vagina, depression, foul mood, irritation, brain fog, memory loss, things like that, can't sleep. But of course, if you have premature osteoporosis or increased cardiac risk, especially when you have strong family history of cardiac risk and strong family history of Alzheimer's, you should go on HRT if you menopause before your time. Next slide, please. Again, how long do we give it for? The National Institute of Health say on average about you are allowed 5 years. But bearing in mind, this 5 years means is for somebody who is already menopause and going back on hormones. If you menopause at the age of 40, it's not 5 years. It's 5 years post average age of menopause. That means 5 years after the age of 50 or 52. So you can use it up to short of 60 years old, essentially. So if you have premature ovarian failure, that means you actually menopause at the age of 38. You have to use it all the way up to the average age of a woman that menopauses is about 52, then plus 5 years. So don't get that confused. And the doctor shouldn't get that confused. It's not just 5 years from the word go. Yeah. And always remember, history of breast or womb cancer, we need to talk about that. History, family history of breast cancer, especially the hormone receptor, we need to talk about that. And you must always, there is this thing called, my symptoms are so bad, I'm suicidal without my hormones, versus my mother had breast cancer. So a lot of it is a one-to-one discussion, the patient and the doctor, and if need be, together with the breast surgeon. Everything must come into discussion, and you have to weigh the pros and cons of using hormones. Okay, next slide, please. So to end it all, what happens when we all get older? Next slide. And what can we do? Lifestyle change, nutrition, all those will account for more than 50%, actually 80%, comparing to our DNA. We used to think our DNA governs 50%, our lifestyle is 50%. Now it's more like 80-20 or even 90-10. Keep good control of chronic degenerative diseases. You must find a good family practitioner that will be able to help you with that. And always remember, supplementation, which is supplements, before hormonal manipulation. Next slide, please. So even though we all start looking nice and cute and young, male and female hormones. Next page. But what we want is this picture. We want to grow old together. So whoever that's giving the male hormone lecture is like what I'm talking about, the female hormones lecture. What you want is to be able to walk down at the end of the rainbow together. So the most important period of a couple's marital lifespan is when you're both menopausing and andropausing. If you both don't understand the symptoms that you're both undergoing. And let me tell you, a man andropause can also have hot flush, can't sleep, low sexual drive, and brain fog. And a man reacts differently from a woman. You know, 4 women who's menopausing come together, and what they do is, hot flush. Oh my God, I hate sex. You know, I just pretend and wish for it to be over, right? We talk about it. You get 4 men coming together. What do they talk about? Ooh, I'm so good. My golf game is so good. I am so strong. But actually, no sex drive, no erection, can't do anything. See, the men, they don't talk. So when all this happens, the man's brain is wired this way. It must be not my fault. It must be my spouse's fault. So either they change and buy a sports car, or they go and ride Harley Davidson, or they change the model of their wife. So it is very, very important. It is so true, Sarah. Don't laugh. It is
that
so
Harley
true.
Davidson is very
true. So true, okay? So true. Why I can say it? Because I'm mid-50s. I can say that. I'm allowed to say it. And it happens to the best of all of us. So if your patients, when they come in for andropause or menopause, come in together, understand why you're feeling the way you're feeling, and both of you will go down this journey and end up like this picture. That is what we want, right? Who cares about sex when you're 70? I mean, some people may, but what you want is companionship, right? Okay, last slide, my last slide. So the goal is not to primarily to prolong your life. We're living long enough already. It's the maintenance of high quality of life into the old age, and of course, the ability to stay engaged. So, last slide. I always end with this slide. And this is not a fake picture, it's a real picture. Okay, so anti-aging medicine is obviously to maximize the healthy, which is a qualitative span, and to minimize the disability span. Okay, last slide. The last of the last. Thank you. Any questions? Do you know what that is?
Yes, it's
that is your kandungan and your ovarium. So cute.
Yep. Yeah, that's so cute. A bit scary, but cute. Thank you very much.
Okay, I see a lot of questions here.
Yeah, I just want to, you said about the ratio of hormones, which we measure when we see the lab, which is normally we see when we look the ratio between the estrogen and estradiol and progesterone. We have to see the ratio, not only the estradiol level, not only the progesterone level. But the issue here in Indonesia, they don't have lab that actually measure that.
Yes, I know.
Yeah, so what do we do?
Estrol in Singapore, we don't have as well. If you want to measure estrol and estrone and estradiol together, you have to send.
Yeah,
you have to send. You don't have a choice. But you know, you have to work with what you have. It's very easy for me to say you do all this wonderful functional testing, estrogen metabolism, all these expensive tests. But hey, all of us have got patients that will only come in and say, I've only got $200 to do.
Yeah.
You deal with my $200 and you see what can you do with it.
Yep.
Because estradiol accounts for a huge majority of our hormones, we go with rule of thumb.
Yep.
Rule of thumb. Don't get too perturbed about estrone, estradiol. Have money? Very good. Most people, no money. You have got to always remember that. And that what makes you a good doctor. Yeah, is to play with what you're given.
Yeah. Yeah. I just want to make it
we
clear
don't
to
have
everyone.
in Asia. No lab in Asia. Don't
No,
get too upset about this estradiol. No. Concentrate estradiol, progesterone, cukup. That is all you need to do.
Okay.
Yeah.
All right. So you also said about the xenoestrogen from plastic and microwave. So, and you suggested to use glass plate.
Glass plate. Yes, glass plate.
What if people use the glass plate? Put it in the microwave.
Okay. Is
less bad or is as bad?
Isn't it going to crack?
No, if it is a microwave plate.
Glass.
Microwave.
I don't think I can answer that question because I do not know. Yeah.
Okay. All right.
Yeah.
Okay. Thanks. Okay.
Old-fashioned way. Put it in the, heat up using the steamer or the old-fashioned way.
Okay. So, there's some question here. You want to read it, or do you need me to read it?
Is it possible to do a lab test? How many estrogen, whatever can we do to reduce? Okay. We cannot measure xenoestrogen. Xenoestrogen is estrone. So if you don't measure estrone, then you can't measure. If you want to measure estrone, you send it out to Australia. The closest to us is IPATH in Melbourne. A bit expensive, yeah? But otherwise, the simplest way of reducing xenoestrogen in your body is to lose weight, because xenoestrogen is stored in adipose tissue. So lose weight. Okay. How to prescribe ratio E to P4? Okay. Now, ratio E2 to P4 is 1 is to 180 or 1 is to 200. So you need about 180 more progesterone than estrogen itself, which is a very, very difficult way to achieve, if you ask me. Very difficult. Very difficult. But that on paper, in theory, if you're doing exam, the examiner, if the question I'll be asking, what kind of ratio do you want to achieve? If you tell me 1 to 2, bang, go home. Okay? You have to tell me 1 is to 200 or 1 is to 180. But to actually achieve that on paper, in practice, very difficult.
Yeah.
Okay. And the ratio with DHEA, I said ratio, but I meant DHEA with cortisol is a different thing. It's another subject. We talk about ratio of DHEA is with cortisol. Sorry, I misspoke that. Okay. And still 40. Well, okay lah. Menopause many years, so I'm no longer 45. So let's see. I have a female patient, menopause. Wow, high blood pressure, huh? In ideal term. Yes, well, you have to remember, functional medicine or integrated practitioner, we are not, we're not like herbologists. We are not crystal ball reader. We do not practice all the way to the end of the world where the moon and the sun must align, okay? We still practice good conventional medicine. That is your first duty. Your first duty is good conventional medicine. The reason why we are better than the normal conventional doctors is because we listen to our patient. We listen to our patient and we treat the patient as a whole. Not 5 symptoms, 5 drugs. But whatever it is, this 45-year-old lady who's already menopause with such high blood pressure, you have to treat the blood pressure first. You must bring it down even before she thinks about losing weight. She goes running, she's going to stroke out. So you have got to bring that down before treating her for anything. So you must be, number one, her primary physician, doctor first. Bring it down, to an acceptable 140/90, 140/85, then we talk. Transdermal progesterone will not impact blood pressure, unlike progestin. Progestin changes your vascular nature. So DVTs, blood pressure, all come from progestin. Now, progestin is not progesterone. Remember that. People get very frightened. High blood pressure, progestin. Yes, we don't do that. High blood pressure, progesterone, no relationship. No relationship. Yeah. Okay, so it's okay to give progesterone. If she doesn't want transdermal, you can give her Estrogen, which is the commercially prepared bioidentical progesterone. Estrogen, 100 milligrams. But if you want to give her 150, you can break it into 2. So that is where the problem becomes a little bit difficult. That's why I like transdermal. But also bearing in mind is the source of your transdermal. I do not know about Indonesia, but in Singapore, we do get quite good compounding pharmacists. So you have to source very good quality compounding pharmacy. So don't forget, what you prescribe is not governed by you, it's governed by somebody else who's making the cream for you. So your reputation is not just you alone. It's got people that making the cream, the source of the stuff. So you have got to do due diligence to make sure that you get all these things properly. Yeah. Insulin resistance, yes. How would you measure her insulin? Blood test, fasting. What is the insulin that you want to see? In the anti-aging world, between 3 and 8. Anything above 8, we call it insulin resistant. And how do we drop insulin resistance? Cardio, cardio, cardio. But if her blood pressure is so tinggi, you better bring it down before she does any cardio. Yeah. Okay. My father, 64. My father and 64. I don't understand Anggi Utami's question. Father passed away 64 years old. Is that what she's saying?
Dr. Anggi?
Yeah, Dr. Anggi?
Yes, I think that is what she's saying.
Yeah.
Doc, her father, I think, passed away at 64. And I think she would like to ask, how can she
As a
be
woman?
longer, yeah. Have
Well,
a longer lifespan. Thank you.
To begin with, thank God we are women. We are already living about 10 years ahead of an average man. So that is to begin with. That's number one. Number two, there are few things that you must make sure that it is well looked after. One is your insulin. Unfortunately, as we get older, every hormones will start to turun. The only one that naik is your insulin. So you must make sure your insulin stays single digit. Cardio, cardio, cardio is to make sure you stay your insulin. And as you get older, you have to eat less. Funny, as you get older, you eat less. Unfortunately, as we get older, our gut enzymes, our intestinal enzymes drop, and all we want to eat is carbo. You notice older people, all they want to eat is bihun, kway teow, and noodles. You give them a piece of steak, they look at it, they're like, because their gut has no more enzymes. And when you have no enzymes, you tend to meander towards carbo. It is a cycle of life. But that is something that if you are very aware, then you at least try to avoid it, right? Being a woman, already we are in the winning end of the stick. But if your father passed away from a lot of heart disease and all that, then you have to make sure that you get your heart checked out. Again, practice conventional medicine before integrated medicine. And if you say, I am menopausing way before my time, hormones until you're about 55 years old, then you fall back into normal population risk for mortality. Yeah. Does DIM clear out estrogen includes? Yes. John, DIM will change your estrogen metabolism because it changes your 2,4,16 hydroxyestrone. And that is what it's all about. The estrone, the cancer causing, that's the one that we want to drive it out of our system. Some hospitals, breast cancer patients, they're already giving them DIM, DIM. And that's quite easy even to get in Indonesia, yeah, Sarah? Yeah. For young infertile, okay. Yes. All right. Infertility, we are seeing more and more and more. And unfortunately, I'll tell you why the problem is. When a woman turns 17, she goes on the pill, and she's on the oral contraceptive pill because she doesn't want to get pregnant. Then she goes on it for 12 years nonstop. 12 years. When she turned 30, oh, I'm married, time to have children. Then she stops the pill. Oops, menses doesn't come. No menstruation. You do blood test, she is not menopause. But why? The ovaries have gone to comatose for 12 years. This is the pattern that we are seeing. It's something you have to tell all your young lady patients. You have to take a holiday if you want to go on the pill. 9 months versus 3 months. 9 months pill, 3 months no pill. You have got to wake the ovaries up and get the ovaries to produce the eggs naturally every year. A lot of women don't do that. They go on the pill for 5, 10, 15 years. Habis, by the time they want to have children, they're not producing. And you know that you need natural estrogen progesterone to actually to get good eggs. Likewise with testosterone, you need your inherent testosterone to produce sperm. So for these kind of cases, you have to use analogs. You have to use Clomid. You don't have a choice. You have to use Clomid to go one above the biochemistry pathway to force the ovaries to exude the eggs. No choice. For a woman, not so bad. She cries a little bit. You do that for a man, he starts crying too, just to get sperm. So we are seeing, unfortunately, more and more, and it's becoming much more of an issue this time around as we get along in life. It is quite sad. It's quite sad. Please, 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 the pill is bad, bad, bad. Okay, the pill is bad, bad, bad. Use a condom. Boys, suck it up. Use a condom. Because when the ovaries is in coma for a decade, it doesn't know how to wake up. Okay. Estrogen dominant, you bring progesterone up. Okay. In estrogen dominant patient, we bring progesterone up. We don't bring estrogen down. We correct the ratio by meeting the estrogen. There is no way to bring the estrogen down anyway. You can try with a bit of DIM to correct the bad side effects of estrogen, but it won't play very much, especially if the patient comes and see you, they're already going cuckoo, you know, they're crying already every month. They're getting big, huge, horrible acne. They are quarreling with their husbands every month. They're yelling at the children every month. They need to be calmed down with progesterone. And I can tell you, a lot of these women, very sadly, have been put on Xanax wrongly. They put on anti-anxiety drugs. So wrong. So wrong. And they get addicted. You know, they can't get off Xanax. When you go into menopause, you get the blues, suddenly go on Prozac. So salah. Correct the ratio. Everything has a ratio. If you have ratio, you'll be okay. Yeah? Prozac, Xanax, please. That should be your last. That is only when we do until what we can do cannot help. Yes, you get the 2% that really needs mental health. That one, yes, fair enough. But it shouldn't be your first, it should be your last. Okay, any adjunct therapy? Yes, some people use EPO, evening primrose. If you use that, it's omega-6, counterbalance with omega-3 because the ratio has got to be 1:1. And otherwise, I use chase tree berry. Chase tree berry is progesterogenic, so it's not bad. Let's see what else. Do I use a HOMA score for insulin resistance? Well, it's quite standard, right? Insulin resistance is a barrage of borderline impact sugar, weighs of more than 100 cm, and low HDL, high LDL, but you just think about it. You just measure the insulin alone. That alone is enough to tell you. And remember, insulin, single digit, single digit. The range, the lab always say the range is 1 to 30. What does that mean? 1 to 30. That's like from here to America. So keep the range small, 3 and 8, between 3 and 8. Okay, last. Exogenous E2P4 shut off. No, it does not. Only Clomid can change That's why the FHA analog, only Clomid. Yes, I know. It's a terrible darn thing for guys. Yes, you use exogenous estradiol progesterone, you actually will not change anything. You're only treating symptoms. You will not produce eggs. You will not produce sperm. You have to use the one above it. Clomiphene, that kind of stuff. All those things. Yeah. So you don't really have a choice. Okay. I think that's the last question. Or
there is this one question, but this is not from. There's a couple of non-doctors here, and one of them is actually your patients from Surabaya.
Yeah, I see her name.
Yep. And now they ask, so if everyone on the elderly needs progesterone, or after the menopause, is the progesterone has to be every day? Or
the good thing with progesterone is when you're menstruating, you got to do it cyclically, right? Some days yes, some days no. But once you're menopause, I think I saw the last question, a 70-year-old woman who can't sleep, is very safe to give progesterone until you're 125.
Yep. Okay.
Yeah? Okay. Yep. So no need to take lorazepam. It may not work on all, but bearing in mind, when you're 70, melatonin is a big problem.
Yes. Yeah.
Okay. So it's not only progesterone.
Yep.
Okay.
Yeah.
But progesterone is safe until you're 100 years old. No issue.
No issue. Now, do you need a holiday for that?
And especially if you're not menstruating, you suka lah. You do 5 days, stop 2 days. You do 1 month, stop 3 days. Up to you.
Yeah. Okay. All right. Thank you very much.
Okay.
Don't look like I think you answered everything. No more question, and you need to be somewhere soon.
Yep.
Right.
Okay. All right. Okay. Thank you.
Thank you very much.
Thank you for having me. Right.
Bye.
Bye.
Thank you, doctor.
Thank you. Thank you.
See you next time.
Yeah.
Thank you, doctor.
Thank you.
Dr. Sarah, should we end the webinar, please?
Yes, we can end the webinar. Thank you. So we meet again tomorrow for Dr. Lenny for the
Okay. So see you all tomorrow. Bye-bye.
Yeah. Bye.
Bye.